depressive disorders. This is kind of a group that kind of show up in the DSM-5. They're all grouped together. One of the updates I made for this, I kind of added in 2 conditions that weren't in the previous deck. One of them being disruptive mood dysregulation, the other one being PMDD. So I added those in there. We'll talk about those as well. Just because it's important to know them, and they are part of this chapter within the DSM-5. Right. So this is your straight pull from your syllabus that we're talking about through here. This is the one that I added in there because it is now officially part of the DSM-5 when we did the update to the TR Type 5 condition. Right. This is kind of like your quick catch-all section. If you actually open up the DSM-5 and flip to the back, you'll see there's a lot of these like other categories. So this is one that I added in there, but like if your depression is caused by a medication, we classify it as this. If your depression is due to a medical condition, so like you have cancer and now you are depressed, we put it down here on the depressive disorder due to a medical condition, right? If you're not really meeting criteria for like major depressive disorder, persistent depressive disorder, but you're still hitting a lot of the signs and symptoms, we kind of drop it down here in this other category. So realize that these other ones exist. I'm probably not going to pull a test question from these 3 down here, just because it's like your catch-all. There's more important ones to know. Unless I'm getting super desperate, I have to create like 50 new questions, in which case sometimes I get desperate in decks. Right? So first one we're going to know about, so this is disruptive mood dysregulation. So when you first read through this, it's going to sound kind of crazy. But we're going to go through the data 3 different ways. Hopefully, the goal is by the end of that, you guys will be super confused. That way I can ask a good question about it, right? Come on, y'all. It's 8 in the morning. That was a good joke, right? So this one, it's important to know, this only occurs in kids, right? So this is not a diagnosis that we're making in adults, okay? That's your first key thing to know. Next, remember from our lecture yesterday, kids, when they have their emotions, they're going to present differently from adults. They tend to be more irritable. They tend to be more angry. They tend to have verbal outbreaks. They throw temper tantrums. Think about it if you have kids, or if you don't have kids, if you go to Target and you're shopping and you see that poor, sad parent in the toy aisle with their kid on the ground, and you walk by and you're like, this is why I never would have kids. Right? Trust me, I've been that parent, and I see you guys looking at me, and I'm like, this is why you have birth control. They're throwing that horrible temper tantrum on the ground. That's that child trying to express their emotions, their frustration, their upset. Right? That's how they're going to categorize it. So the biggest thing is category A has to be there. So you have these pretty severe verbal outbursts or temper tantrums, right? Big thing to know with this is it's not going to be age appropriate. Like your 7-year-old, your 8-year-old should not be having major breakdowns and temper outbursts, right? Next, it's going to be out of proportion to the situation. So if I tell you, like, hey, you need to go to bed, it's your bedtime, and they have a complete breakdown and freak out, that's not appropriate to the situation. So now we've satisfied the very first category, right? Next, category B, it's inappropriate with the milestones where that child is at. So remember, if you're like 3, 4, those kids are just starting to talk, they're just starting to walk, it's okay for them to have outbursts and crying and stuff like that. Once you start to hit a 7, 8-year-old, 9-year-old, 10-year-old, now all of a sudden it starts to become less appropriate. They should be able to kind of communicate a little bit better. They should be able to regulate their emotions a little bit better. They're at those milestones, okay? Next one, so that satisfies category B. Next, category C, the outbursts. So again, with a lot of our conditions, this can't be a one-off that shows up one single time and never again. It has to be numerous, so over the course of that week there has to be a lot of episodes, and it has to be over time in order to satisfy that next category, right? Next thing, when you're talking about pediatric disorders, a lot of times we want to see it in different environments and other people have to observe it, right? That's why if you've ever had a kid evaluated for like dyslexia, ADHD, when we're doing those forms, we get one from the parent because we want to know the parent's opinion. We usually are going to get one from the teacher because we want to know how they perform at school. Sometimes we'll get one from a sports coach, we'll get one from daycare. We want to get multiple opinions because a lot of times kids, sometimes they have a bad relationship with their parent and that reflects in the household. And then when they go to school, they're outside of that bad environment, and now all of a sudden they behave appropriately. So they don't meet criteria, right? Or you get the reverse. Sometimes in school, you just have a bad teacher and you don't necessarily like the environment that you're in, you don't like the class that you're in, so you act out, right? But then as soon as you go home, like parents are like, oh no, he's an angel. He always takes out the trash, plays with his brother and his sister. So there's a disconnect. So anytime you're dealing with kids, it has to be across multiple different environments, okay? So that would take care of this one, and then that kind of takes care of your category E. This is another time frame. So again, greater than 12 months. So we want those symptoms to be present, and they can go no more than 3 months without an episode, right? So that means they can have, the symptoms will go away for a little bit, but then they'll come right back, right? And as long as they're not hitting that 3-month mark, they're still going to meet that criteria. Then, again, you want it at multiple locations. You're always going to ask for different opinions to make sure they're still meeting that criteria. So once you hit F, now you can start to go down into this. Remember, this is a kid's disorder, so our cutoff is going to be 18 years of age, right there. And another big thing is, we don't make this diagnosis in young kids. So like your toddlers, we don't do that. They have to be over the age of 6, right? So again, that's going to sound a little bit crazy when you look at this next one. All that's saying is when I make this diagnosis, they have to be over the age of 6. The symptoms have to have shown up before the age of 10, right? They don't necessarily have to have the diagnosis yet, but I should start seeing a pattern and trends that are coming out before they hit the age of 10. If they're over the age of 10 and now all of a sudden they're starting to show these symptoms, and I don't have history of it ever again, it's going to be a different disorder that we'll learn about when we're talking about the childhood development, right? So kind of keep that in mind. It sounds a little bit crazy when you're looking at the map. Hopefully you can think about it that way. We'll go through it again. You can hit it multiple times. Hopefully it'll kind of start to sink in at that point, right? And these are your catch-alls. They have to be there for multiple different things. Again, it can't be better explained by another condition, can't be explained by a substance, it can't be explained by something else, right? The reason that this disorder was added to the DSM-5 TR is because child psychiatrists, they were over-diagnosing bipolar disorder, and the kids didn't necessarily have bipolar disorder. If you guys remember your meds, the moment I make that diagnosis, now all of a sudden I have to dump on mood stabilizers, I might need antipsychotics, I might need all sorts of meds to control bipolar. So you're putting a whole bunch of meds with a lot of horrible side effects on a relatively young kid, and maybe they didn't need that criteria, they actually had something else going on. That's where they came up with this disorder and added it into the DSM-5. So it's so that we have something else to diagnose them with besides bipolar disorder, okay? So this is the quick rundown in a nutshell. Next one, so this is your pink box criteria. So I went in and actually pulled the snapshots from the DSM-5. This is just another way to look at that material. Unfortunately, it's going to be like 3 slides because I didn't want to condense it all into one slide deck because it would be super small. But as you can kind of see, we start to get that same criteria. This is just another way to look at it. They use different verbiages, different words to describe this stuff. This is directly from there, right? Again, outbursts, so verbally or aggressively occurring out of proportion to the situation. Outbursts are inconsistent with that development level, so if it's a 10-year-old having a temper tantrum, not appropriate, right? You're averaging 3 times a week or more, so again, it has to be occurring frequently enough for me to be concerned about it. A one-off, I'm not worried about, right? Present for at least 12 months, and then they can't have a break in symptoms for greater than 3 months, so they can't go into remission more than 3 months, if that makes sense, right? Then down here, at least 2 of the 3 settings. So again, you want this with school, peer groups, sports, at the home front, wherever it happens to be. It needs to be in multiple locations. This is your next one down. So again, can't be before the age of 6, can't be after the age of 18. This is a kid's diagnosis. And we want the symptoms to be there before the age of 10. They don't have to have the diagnosis, but they have to be showing signs and symptoms consistent with this disorder before the age of 10. Okay? Next, this is kind of more than one day because if it's a one singular episode, that changes your diagnosis. Bipolar disorder is episodic. So they'll have a really bad episode that kind of goes over maybe a week or 2 weeks, and then they go completely in remission where they don't have any signs or symptoms, and then it flares up again. This one is persistent, so it's 3 or more times, it's always there, and it's over time. That's what kind of separates the two when you're thinking about it. Is this episodic? Is this an impulse control? or is this always there? That's how you're going to differentiate. Yes?
So if a kid is unlucky enough to have bad parents and a bad teacher,
Yep.
he's going to get diagnosed with a disorder?
Yep, it's not illegal to mess up your kids, right? Unfortunately. That's why we always want to get multiple opinions. We want it over time, right? And sometimes it takes us a little bit to make a diagnosis. We're going to want to see them back a couple of times so we can track and trend this over time. Because it's also going to depend on how they're interacting with you in that exam room, right? Because if you're seeing one thing, we're like, this kid's acting perfectly fine. He's super polite. He's sitting in his chair nice and calm. He's talking back and forth with me. I'm not worried about the diagnosis, right? So you also have your opinion to take into account as well as the clinician. Make sense? Yeah. And that's where if I'm worried about both, I try to get like, hey, are they in sports? Are they in daycare peer groups? So hey, kind of talk with some of your friends, gather that collateral information, right? Because a lot of times if they have a bad life, bad home, they have a friend, and they'll go and they constantly hang out at that friend's house because they're trying to escape that environment. Cool. All right. Good. This is added in by the DSM-5 criteria. This is where they're talking about bipolar disorder and why we don't want to diagnose it or when we switch over. Okay. Good. And this is those last criteria. Again, a lot more information considered in with this that you guys can read through. And that kind of gives some background info to this diagnosis and stuff like that when you're looking at the disorders. Yeah. Cool. So your differentials, there's a lot that can coexist. Don't worry so much right now at comorbid conditions. At the primary care level, I would not expect you guys to diagnose multiple comorbidities. You may get that patient once they're stabilized and managed by Psych, they'll come back to y'all. But really, if you can make one singular diagnosis, that's really what I want. And then you consider the appropriate care. And as we're interviewing them and talking to them, we can add on those extra diagnoses if we need to. Good. So, this is just one last, if I had to think about what is like the core criteria for this disorder, if this has to be there in order to make this diagnosis, I put this all kind of broken down into one slide, right? So remember, it's a disruption of their mood that's chronic, severe, and persistent. So it has to be there multiple times, right? So two prominent clinical manifestations, it can either be temper outbursts, irritability, or an angry mood. It can be any of those. And that can represent itself in a verbal, where they're just screaming and yelling. They can be behavioral, where they're not really obeying commands or not being appropriate, or they can be getting into fights and things like that. There's different ways it can present itself, right? Outbursts are usually in response to frustration. So again, they just don't have a good way to express their emotions. They have this overwhelming frustration, this anger, this anxiety that's coming out of these very simple situations, right? Next, present for greater than 1 year. Again, that's 12 months. Present in 2 or more settings. Noticeable by other kids in the environment. This is where it's helpful to get that collateral information, talk to other parents. If they have friends, see if you can talk to the friends and stuff like that. See what's going on. This is where school counselors come in handy. Yes?
Sir, for most of the disorders, do you need to get that?
For what part?
1 year.
Not necessarily. Time frames are always going to matter, but as you'll see with the rest of these disorders we're going to talk about today, they all have a different time frame, right? So like a great example was major depressive disorder. It's only 2 weeks. But there's always going to be a time frame combined in with these disorders and stuff like that, right? So not necessarily 1 year, but we do use that one quite frequently. Did I answer the question? Okay. Good. All right, and again, before the age of 6, or after the age of 6, before the age of 10, once they hit 18, that diagnosis is going to change over to something else. This is your prevalency rate. Again, of all the kids in the world, not super common. You're talking about 2 to 3% of them are going to meet the criteria for this diagnosis, okay? And again, it was added in there to kind of reduce bipolar disorder, that number of diagnoses. Yep.
So what does this turn into when they turn 18?
Great question. So once they turn 18, a lot of times these kids are going to convert over either to major depressive disorder, anxiety disorder, or personality disorder. They're going to start to meet that criteria for one of the other ones, and they'll convert over. Yep. Yep. All right. So again, I've kind of given you the criteria 3 different ways. You can pick the one that you like the most to kind of meet that criteria. Biggest thing I would say, remember, they have to meet the first bucket before you can ever move on to the second one, right? So just because they're angry and irritated, if it's not that very first one, where it's disruptive mood, it's chronic and persistent, they don't meet that criteria. So before you can move on to the next one, They have to meet it. So when you're thinking about studying for these, they have to meet the first bucket before you move to the second, before you move to the second. If any one of those buckets is not filled, then they don't meet criteria for the diagnosis. Okay. All right, so that's the first one. This is your differential diagnosis. So this is kind of other things it can be. They all present a little bit differently. So bipolar disorder, remember, DMDD is persistent, while bipolar disorder is episodic. Opposites refined disorder, this is where like you get a kid who just is not behaving, they kind of delve into that realm of legal concerns, or kind of like a jerk. This is more of an impulse control issue rather than a mood issue, right? They're just a jerk for no reason, essentially, right? ADHD, this is sometimes gets confused with it because an ADHD kid, if you've ever met one, right, they're like bouncing all over the walls or up and down chairs or climbing all over stuff. You can't get them to focus. So sometimes those kids, you're trying to control them and they don't respond well to that and they act out because they just can't do it physically. So that's an ADHD diagnosis and why people deal with this. And last one, intermittent explosive disorder. This is that severe sudden outburst, like they are perfectly fine, and all of a sudden they just have an explosion of rage. In adults, this looks like road rage, right? Like you have a perfectly fine mom, the moment you put her behind a wheel in San Antonio, she turns into a mean monster, right? That's explosive disorder. Great. So, next we're going to talk about depressive disorder. And this one is great because there's like a visual we can go with this. If I can get my mouse to go to the one that I want. I don't like this. I hate having multiple screens. This screen is horrible. So, when you guys are thinking about depression, and especially like adults, the person I want you to kind of, if you're a visual person, to keep in your mind is Eeyore, right? Like, he is your classic caricature of somebody who is depressed, right? So, if you're thinking about your AMSET, your appearance, right, how would you kind of like describe Eeyore using your AMSET? What's that? Reserve? Good. What's that? Yeah, so thinking about his general appearance, right? He always looks really tired, right? His eyes are always half closed. He's always hunched over, right? Kind of doesn't have a great posture. He's always kind of like pulling back in, so that's his appearance, right? If he was dressed in clothes, you would almost say that he's kind of almost looks disheveled, right? Might not be clean shaven, hair might not be pulled back, might be wearing oversized clothes and stuff like that. Good. How would you describe his speech pattern? Is it quick, rapid, fast? No, it's very slow, right? He's always very slow to respond. He's always very monotone in his speech, right? He doesn't have a lot of inflection. It's hard to kind of gauge him as like being ever happy. Even when he says he's happy, he's still using that very monotone voice, right? How does he move? He's always moving very slow, right? He's always kind of meandering along. He's never like really running. He's never really jumping. It's like a very rare scenario. Very slow psychomotor activation, right? He's not super like running around doing things, right? And then so that's your appearance. We kind of satisfied a lot of those, right? He's not really having like mimicking speech, not mimicking your emotions that would lead us down the road to something like a bipolar disorder or a psychosis, right? Not meeting that criteria. He's never very slow, looks tired, looks sad. He has that appearance of a depressed person, right? So next you go to M, right? So kind of mood. So how would Eeyore describe his mood? What's that? Sad, right? He's like, everything bad happens to me. Like, he's very sad, right? Even when he says, like, I'm doing well, you're like, are you really doing well? You don't sound like it. So that's his mood. He might say he's sad. He might say he's happy. That's the subjective, right? So then we go into affect. Affect is objective. How would you all describe his mood? Depressed, right? Good. Is he super labile? Is his mood jumping from super happy to super sad? No, right? He constantly stays in that depressive state. So his affect you would describe as depressed. You might even say restricted affect. So he doesn't have a broad range of emotions, right? His emotions tend to stay on that depressive spectrum, okay? He doesn't necessarily have a flat affect. Flat affect is zero emotions whatsoever. That tends to be more in a schizophrenic patient, but definitely very depressed. You can tell he looks depressed, right? So next you go into sensorium. Are you ever concerned about sensorium with Eeyore? Does he always know where he is? He knows where he is. He's in the 100-acre woods, right? He's always kind of oriented to person, place, time, right? You would assume he can probably do some calculating abilities. You're not worried about his sensorium being degraded, right? He's probably a little bit slower to answer, but not necessarily to the point where you're worried he might have like a dementia, delirium, or psychosis, or something else going on. So that's your sensorium, right? That's where you're talking about your calculating ability, concentrating ability, orientation to person, place, and time under that category, right? So AMSI. So next is going to be your intelligence. So again, your intelligence, it's your best guess based on the information that you have. Are you worried about Eeyore's intelligence at all? No, right? So again, you're going to basically say, like, he's probably average intelligence. I'm not worried about him having like this grandiosity where he thinks he's a PhD in psychophysics. I'm not worried about him being in like a childhood state where maybe he has like regression in his milestones and stuff like that, right? So again, his intelligence is intact. Good. So next one, we're going to the last category, which is going to be thought. So is he clear and logical?
Sure.
Right? Yeah. He's making sense. Like, yeah, he's depressed, he's sad, but he's always, his train of thought is connected. It's coherent. I can follow along with him, right? Would you say that his judgment is sound? Do you feel like he can take care of himself? Yeah, maybe there's a little bit of a degradation in that judgment because you're like, dude, the world's not always angry and sad, right? But you can still kind of follow along, so you're not worried too much about his judgment. What about his thought? Is he able to answer questions, or is he going off on these crazy tangents where you have no idea what's going on, and now all of a sudden he's talking about regrowing organs? Right? No. So his thought is intact, right? So judgment, maybe a little bit of degradation down in there. And then finally, kind of what would you say about like his insight into the situation? Does he have good insight into his condition? Yeah, he has good insight into his condition. So now you can kind of see how we use that CAM set. The only thing we didn't talk about was like talking about proverbs or comparisons. I would say he was probably able to do that, so you're not worried about like a psychosis, a bipolar disorder, or schizophrenia, things along those lines. But now you guys can kind of get an idea of how we use that AMSET to inform our decision when we're talking about these disorders. So anytime you're worried about a depressive patient, kind of think back to Eeyore and how he acts. He is a very good caricature of depression. Okay? Good. So, biggest thing when you're talking about depression is they have to have this criteria first, so it needs to be present for at least 2 weeks. Right? If it's less than 2 weeks, then they don't meet that very first criteria. Next, they must have either a depressed mood or a loss of interest. If one of those is not there, they're not meeting that next bucket, you can't move on, right? Then after that, so this is your mnemonic SIGI caps. It's a pretty classic one when you're thinking about the signs and symptoms that we're going to go on in just a second. They only need to have 4. So the minimum is 4, but they can have all of them. That's your cutoff right there. When you're talking about prevalence within the U.S. specifically, DSM-5 is going to say, or TR is going to say it's at about 7%. Some of the newer research that's just coming out, it's probably about 10% or a little bit higher of the population is going to have a depressive order at some point in time within their life, right? Lastly, so mnemonic-wise, I've never been a big mnemonics person, just because I always had a hard time keeping them straight. But some people really love mnemonics. It's another way to kind of synthesize this information. So there's 101 different mnemonics that are out there, especially when we're talking about mental health. This is something that I've kind of kept with me as I've gone through school, and I uploaded it into the Canvas page. So if you guys like mnemonics and want some different ideas, this can be a resource that you have. And this one's specific to psychiatric disorders. And they're just kind of going through all the different mnemonics you can have. So there's your Psyche caps, right? Your cage, your WIMPs, and it kind of breaks them down by condition. So there's your Psyche caps, dysthymia, mania. And this is another resource that you can use. Like there's another kind of variation that you guys can use if you like mnemonics. Okay, that's your resource. I just wanted to point that out to y'all before we keep going. So again, remember, with kids, they're always going to present a little bit differently. They're always going to have that irritability, more that anger, those temporary outbursts when you're talking about depression, right? So at 2 weeks, these are your symptoms. They only need to have 4 of them. Believe it or not, they don't have to be suicidal. They don't have to be morbid ideation. They don't have to have homicidal intent. If it's there, they're at risk for it. But to diagnose a depressed person, they don't have to want to kill themselves, right? Not all depressed people want to kill themselves. It's kind of like a little bit of a misnomer that goes on about that, right? Next, clinically significant, as with all of our conditions, it has to have some sort of impact on their life. If they're still having a great marriage, they're hanging out with their friends, they're successful at work, they're not having any impediment in any of those aspects, then they're not satisfying that very last criteria. And then as with all of our conditions, the last 2 have to be there, right? So not caused by another condition. So a common one, thinking along the lines of like thyroid. So if you're hypothyroid, it can definitely mimic a lot of depressive symptoms. And again, can't be caused by a substance or induced by withdrawal or something along those lines. That's going to be pretty standard again. You're going to see that ad nauseum. Right? So this is your pink box. This is your breakdown for Psyche caps. Right? So sleep can be either hypo or hyper. So they're either sleeping a lot or sleeping a little. Interest. So they have to lose interest, right? They can't. So a great question I like to ask people is like, hey, what do you normally like to go out and do? Well, I like to go out and go bowling. You're like, great. Are you still bowling? Yeah, I still go out and bowl. Like, are you still getting joy from bowling? If they go, no, I don't really get any joy from bowling. That's a way you can ask those questions, right? Are they still having interest in it? Guilt. They feel guilty about their condition or guilty about something that's going on, right? Energy. This is going to be that low mood. Again, think that Eeyore. It's very low energy. They don't want to go out and do anything. They're fatigued. They don't have the energy to get off the couch and exercise, go see friends, go to work. They just don't. Concentration. This is going to be that poor concentration. They're not going to really be able to focus on a topic. They're not going to be able to complete a project. They're going to start something and then it will fall off. And this is where you can sometimes get a little bit of mimicry with ADHD in the adult population. A lot of these symptoms tend to kind of coalesce together. Appetite. So this can be either overeating or undereating. It can be either one. So you always want to ask them how their diet is, what their nutrition is. This is why it's great. You always want to get a weight on your patients, so that way you know where their baseline is, and over time, if they're going higher or lower, it's something you can track and trend. It gives you a little bit of objective data to talk about these very subjective complaints, right? Psychomotor, this is going to be that retardation. So again, not retarded as in the education level, retarded as in like just their movements are going to be very slow. They're going to be slow to react, okay? And suicidal, homicidal, or morbid ideation. The morbid ideation is more just kind of like that obsession, whereas they might have actual thoughts and plans. So it's very important to kind of clarify that data the moment somebody says they're having thoughts about dying. You really want to jump in there and figure out exactly what's going on. So this is, again, continuation of that pink box. You can see there's a lot of extra information in there. So you can definitely read those through if you want. Because again, it kind of gives a lot of that background data to why we put this criteria in there and why it wasn't something else. Good. So there is again, I'm not going to really text you on this, just put the circle in there. This is more just for y'all's information. Recognize that there is a genetic component when we're talking about psychiatric conditions. And this is where it's important to ask that background information on the family members, right? Like, hey, do you ever have a mom or a dad, firstborn relative who's had like a major depressive episode? When were they diagnosed? Did they ever go into remission? If there's family trends, it can be very helpful in kind of linking into these disorders and these diagnoses, because there's definitely a genetic component. We don't know specifically what genes cause it. We tend to think more along the lines of epigenetics, where you're exposed to certain things, you already have these risk factors, and it's like a series of light switches that get turned on and off depending on where you are in your life. Okay. Next, just recognize women are going to be at a higher risk for developing major depressive disorder. because you're dealing a lot with hormones, estrogen, luteinizing hormone, and depending where they are in their reproductive cycle, right? Somebody who's about to enter menarche, they get this huge surge in their estrogen and other hormones, causes some problems, right? Depending on where they are in that menstrual cycle, you get those hormones that are all over the place, that can lead to some issues. And then on the reverse side of that, when somebody's getting ready to go into postmenopause and perimenopause, now all of a sudden you're getting that reduction in those hormones, that can lead to some problems as well. So again, something to worry about and think about with our female population, because that's 50% of the population we're going to be working with. We need to be aware of where they are within their reproductive cycle. It doesn't guarantee it, don't ever think that, but it's you're just stacking risk factors on top. Right? So PHQ-2, you guys are all pretty familiar with these screeners. It's literally part of the PHA that we all have to do. And really the very first thing you're asking is these two. The little interest or pleasure in doing things, feeling down, depressed, or hopeless. That's your very first criteria, right? So remember, you have to have one or the other. If you don't have either one, you don't meet criteria. That's your PHQ-2. It's your initial screener. Everyone usually gets this. Then, if they pop positive for one of these, oh, hold on, it'll be coming over. There it is. If they pop positive for one of those, then you go ahead and give them that full PHQ-9, and that's where we actually go into the CITY-CAPS criteria. That's what you're using to screen that. And again, remember, they have to have a minimum of 4, but they can have more, right? Again, you are right there. Always kind of keep this guy in mind when you're talking about a depressive patient. Is this an EOR that I'm dealing with, right? Good. This is kind of like that quick bottom line up front when you're talking about major depressive disorder. So, high mortality, remember we talked about with suicide, these people are going to be at like a 20 to 30% increased risk for suicide. Anytime somebody has a mood disorder, something to be aware about. Suicidal thoughts, like we talked, they range from just the passive thoughts of death, this is morbid ideation, to actually coming up with a plan. The more information they have, the more concrete, the more risk factors, the less likely you are to release them and let them go home. Okay. Good. Treatment-wise, so cognitive behavioral therapy is definitely one of the top treatments for major depressive disorder. And cognitive behavioral therapy, just so you all know, it's a manualized therapy. That's why we really like it. And it tends to focus more on the building blocks of how to cope with different things, right? So essentially we're identifying somebody's negative cognitions. So like we talked about with like the all or nothing thinking, the catastrophizing, we're helping them identify those. And then we're coming up with a plan with them in mind on how to approach that, right? So it's a series you're usually looking at like 10 to 14 sessions with a therapist that you're going through. You actually get assigned homework that you actually have to go and do. So if your patient's not engaging with the homework, they're not necessarily going to get better. And a big thing with CBT is we're focusing on a very small goal. So if we can make these very small incremental changes with a depressed person, they'll get better over time. If you attack a depressed person with a major goal, they're going to immediately fail and it's going to worsen their depressive symptoms. So when you guys are coming up with a treatment plan, let's say you want them to exercise, right? If you just tell them, hey, I know you're depressed right now, you know it's going to make you better, running 60 minutes a day, 5 days out of the week. That is a very hard goal for a depressed person to reach. Like, yeah, it'd be great if they did that. It's definitely going to improve their health, but that's not realistic for where they are in their scenario, right? So you start off with something small, like, hey, is it reasonable that you can go outside your apartment building and do a lap around the building twice a week? It's a very small goal. It's reasonable. And if they can meet that, it's actually going to be like, hey, I can accomplish something. It gives them a reward. And then you slowly, over time, ratchet up those goals, right? And that's how you approach a depressed patient. That's just something to make you guys better clinicians, because you guys are going to encounter this a lot on the primary care side. Good. Acupuncture, phototherapy. This kind of goes into seasonal affective disorder, which is a subcategory within like the major depression. Has anybody ever been to Alaska? Having Alaska people, right?
Yeah.
So what happens with the sun?
It goes away.
It goes away, right? And then so that sunlight, we definitely, as human beings, we need it. It drops our vitamin D levels because we're not getting any sunshine anymore. You can actually enter a depressive state because of that. And that's why we actually have these sun lamps, right? And you just go and to supplement the sun, you sit in front of your sun lamp, and that's how you get that phototherapy. Believe it or not, who's my Air Force? So the skiff for you all believe it or not, I swear I've had a couple of seasonal affective disorders from people who were intel and the drone operators, because literally they go in the morning before the sun comes out, they go straight into the skiff, and there's like no windows in the skiff, right? It's completely blacked out, and then they're there for the entire day. Their shift ends, the sun is down, and then they go straight home. So they're never actually getting any sunlight because of the building that they work in. That's why it's important to know like your occupation and what this person's actually doing, because it's going to play a part in them. And I was talking with some of them, and I think they have like some sun lamps and stuff like that within the ships themselves because of this issue, right? So be aware of that. Phototherapy, so ECT, we talked about that the other day. Electroconvulsive therapy, it's a great treatment, just recognize there are some risks associated with it. Essentially what you're doing, you ever taking your computer and they tell you like turn it off and turn it back on again? That's essentially what we're doing with the brain, right? We're gonna turn it off, turn it back on again, and hopefully we get a good reset. We'll see what happens, right? And it works. So SSRIs, so believe it or not, when you're looking at the VA treatment guidelines, when you're talking about therapy versus a medication, for mild to moderate depression, they 50% for both, right? So they kind of say like, hey, ask the patient what they want to do and go with that route, because one's not necessarily better than the other. They've both been shown to help with remission. When you're talking about lifelong, obviously therapy is going to be better because we're teaching them life skills that they can incorporate throughout their life, whereas a med, the moment you stop it, it stops doing its job, right? But there's mild and moderates, either one is fine depending on patient preference. Once you start to get into severe depression, moderate depression, kind of on the tail end of it, that's where we like combo therapy. If we can get a therapist going and add on a med, that's where we get the best effect. They work synergistically, right? When you're picking your SSRI, this is where it turns a little bit more into an art form, because they all generally do the exact same thing, right? They all have that indication for depression. But when we want to use those side effects, and we can use those side effects to our benefit or our detriment, we want to tie that in to the patient. So if I have somebody who has no energy, they can't get out of bed, and that's like their predominant complaint, well, I can hit them with fluoxetine, because it tends to be a little bit more activating, right? Or Wellbutrin, because it tends to be a little bit more activating. And if I have somebody who can't sleep at night and they're losing weight, I can get them with paroxetine, because it tends to cause weight gain, it makes them super sedated, so sometimes I can get a 2-for-1 when I'm talking with my meds, right? If I have somebody who's very mild and I'm not like 100% with like the depression diagnosis, but they really want a med, I'll usually go with like escitalopram, because it has a pretty decent side effect profile and it's pretty easy to dose. You either like 1 and 2, you're done, right? And sertraline is a tried and true. Sertraline is great if I think I'm going to need to work with this patient, because it gives me a huge window to work with. It goes all the way from 50 all the way up to 200 milligrams. So that's where sertraline can come in and be super helpful. SNRIs, if your patient has comorbid pain, so maybe they have fibromyalgia, maybe they have neuropathic pain, now we can go into their SNRIs. And now, because they have that pain indication, I can use those meds with better effect. Good. DCAs, MOIs, stimulants. I don't necessarily use stimulants for major depressive disorder. At the primary care level, I wouldn't want you guys to do that just because of that abuse potential. If I'm reaching down into my bag for kind of this level and this level, that's more along the lines of psychiatry, behavioral health. They should be doing that just because there's more risk associated with it. Good. Therapy-wise, again, remember, 6 months to 12 months, that's how long we want to continue the meds once they've entered remission. And then I have plenty of people that continue on their med for the rest of their life, right? But we can also discontinue it once they've hit that 12-month mark, and we just reassess them, make sure they're doing well, make sure their symptoms don't come flaring back, and then make a note in their chart, be like, hey, this med worked really well for them. They had a really great response at this dose. That way, 2 or 3 years down the road, if their symptoms come flaring back, I hit them straight with the med that already works, saves us a little bit of time. There's a flow chart. I'm not going to read this guys to you, but again, if you like flow charts, you can use this. Right? Good. So that's your differential diagnosis when you're talking about MDD. Just it can be routine sadness. Remember, they have to meet each one of those criteria to make this diagnosis. So next, we're going to move into persistent depressive disorder. The thing that makes these two disorders different is time frame. It's where it's important to know your time. So this one, you're talking about years, right? This is not a short 2 weeks. They've been in a depressive state they've just been living like that for, I think, if I remember correctly, it's 2 years. We'll find out if I'm right in just a second. Ha! The reason I was not right? I still know these. All right, so 2 years plus 2 of these. So the criteria is a little bit lower, but the time frame is a lot higher. And there is some argument that this actually should be a personality disorder rather than a mood disorder. This is just how that person is. We've all encountered people like this. You're like, oh man, that guy, I don't like hanging out with him. He's just super negative all the time. That's because they have persistent depressive disorder, right? These guys are super hard to work with. The meds start to become a lot less effective because they've just been like that for so long. And therapy becomes a lot harder because they have this expectation like, oh, I haven't been well in 2+ years. Why would this 14 sessions make me better, right? So sometimes these patients can be a little bit harder to work with. So there's your pink box criteria. We're talking about persistent depressive disorder. Good. Otherwise, your treatments are going to be exactly the same as major depressive disorder, right? The treatments don't change at all. This just becomes a little bit more difficult. So this is your differential diagnosis. When we're talking about persistent, biggest thing to keep in mind, remember that time frame has to be there. They have to be 2 years or more. The symptoms can be a little bit less. They only have to meet 2 of the symptoms rather than the full 4 for a major depressive disorder. If they can have more than that, they can't have less. Okay. Good. Premenstrual disorder, I added this one in there. This one is specific to female population, and this all ties into their menstrual cycle, right? So essentially, as they're gearing up to enter menses, they have this huge flood of hormones, and that triggers a mood disorder, right? Then they enter menses, and all of a sudden moods drop back down, and now those symptoms go away, and we're able to tie this. So this isn't just like a one-off. It's always tied to menstrual cycle, and it reoccurs over time. It's going to be cyclical, right? This is why when you're taking your history, it's important to ask when the last menstrual period was, how long that period lasted for them, and is that a normal menses for them? And then you can tie that to what symptoms were you having at that time, okay? This one's a little bit unique because you have to have a total of 5, but it has to be at least 1 in category B and at least 1 in category C. You add those together, and then you have a total greater than 5, right? If all their symptoms are only in B, they don't meet criteria. If all their symptoms are only in C, they don't meet criteria. They have to have both. Okay, there's your pink box. I'm going to have to break it down to a couple of slides. That way it would all just fit in here nice and neat. There's your first one. Occurs with that menstrual cycle. They have to have a total of 5. So 1 or more of the following. So this is kind of like your depressive symptoms. Right here can be anxiety, can be depressed mood, irritability, anger, affect, liability. So they swing from happy to sad very rapidly. That's what we're talking about when somebody has a labile mood. Right? And then category C. So this is where you kind of get that poor concentration, lethargy, hypersomnia, insomnia, sense of being overwhelmed. You have to have some of this stuff. That's kind of like your mood symptoms. Or physical sensations, that's kind of like when people complain about abdominal pain, maybe breast tenderness, weight gain, that would be there as well. Right? And this is kind of like, again, your catch-all category, so it has to cause some sort of distress, not an exacerbation of some other disorder that's within there, right? Can't be caused by something else, can't be another condition. So always rule out organic causes, okay? So this is kind of like the bottom line up front when you're talking about PMDD. This is, in my mind, like this category has to be there when you're talking about them. So mood, lability, irritability, dysphoria, and anxiety occur repeatedly during the premenstrual phase and remit at the onset of menses. So it has to be there before, and then it goes away once menses starts, right? The psych symptoms are accompanied by behavioral or physical, so that's where you kind of like have that depressed mood, that lability, you don't have joy or pleasure, but then it can also be with anger, irritability, bloat, pain, something along those lines. They both have to be there, right? You're looking at 1 year, so it has to be within the past year. It's cyclical. It's happened multiple times, right? It can't be just a one-off, right? And then that symptom-free period is going to be important. So that's whereas with depression, it stays there the entire time. With persistent depression disorder, now you're talking about over 2 years. This one, it's still within that last year, but it shows up, goes away. Shows up, goes away. shows up, goes away. That's how you kind of differentiate all of these apart, right? Otherwise, treatment-wise, it's going to be the same. Usually with this one, it's less on the therapy side of it. And right now, the primary treatment is going to be SSRIs. And they're just going to take that continuously. There is some benefit to also getting them on birth control. That can help with the hormone regulation. But it's not as clear-cut. But I would definitely say when I'm trying to deal with these disorders, stacking multiple things together can make a difference, right? Especially if they have like super heavy menses or it's super erratic, trying to get them on some sort of regular pattern can be helpful. All right, there's your prevalency rate. Okay, so these next couple slides are kind of more focused on just some practice. We'll roll through a couple of them, just to kind of get you guys some reps. But otherwise, that's like the big bulk for depressive disorders. Any questions about those? Because we're pretty much done. Go once, twice, 3 times. So I won't go through all of these. Real quick, so there are specifiers. I don't expect you guys to know the specifier, like actually make a specifier diagnosis of mild, moderate, and severe. Biggest thing for you all is keep in mind the more symptoms they have, the next category up they're going to be. So if they only have the 4, they're mild. If they have all of them, they're severe. Kind of in a nutshell, that's how you break it down. There are specifiers that exist within the DSM-5. You guys can just make the diagnosis of major depressive disorder. I love that. I'm happy with that. Right? So this is kind of like a breakdown. This is kind of a good idea of how these questions are going to start looking. They're going to be a lot more of that scenario-based, right? And then what will happen at the end is I'll add a question. So I'll say, what is the most likely diagnosis? And you'll have to pick from 1 to 5. Or what is the most appropriate medication? Or what is the next step in treatment plan? So a lot of times we'll get a scenario. It'll all kind of start like this. And I'm going to ask you a question at the end. Okay? So with this guy, so a 29-year-old female participant follow-up has a diagnosis of MDD that she reports feeling worse over the last couple of weeks. She endorses depressed mood with worsening difficulty to sleep, weight gain, eating too much, insomnia, concentration deficits, fatigue, anhedonia. Feels terrible amount of remorse, always missing her children's soccer games. So, what is the diagnosis? Yeah, major depressive disorder, right? Perfect. What if I told you that she's been feeling like this for 2 years? Persistent, right? What if I told you she always felt like this right at the start of her menstrual cycle? Right, good. So you can kind of see the symptoms are going to be very similar, that time frame, and how the symptoms are presenting is how you're going to differentiate all of these together. Perfect. What was your guys' treatment? SSRIs or CBT. Perfect, right? That's awesome. What if I told you she was having difficulty sleeping and she was losing weight? Paroxetine, right? What if I said, what is the least appropriate med for this person? I told you she had a heart condition. Citalopram, right? So now you guys kind of see how we ask those questions and tweak them just to make them harder or easier depending on how I'm feeling that day. All right, so this is the next one. So a 34-year-old male physically with 3 weeks of depressed mood. He endorses some associated difficulty sleeping, eating, concentrating, and no longer wants to play golf with his friends and used to be his favorite thing to do. He's still able to accomplish work and home responsibilities without a problem. No SI or HI in a benign exam today. So what is this guy's diagnosis? Sad, right? Because is he having those effects somewhere else in his life? No, not really. So based on the information that you have, he's not meeting criteria for major depressive disorder. Yes, he's hitting a lot of the boxes, but it has to have some sort of detrimental effect on his life somewhere, right? Now, if this was a real patient, I guarantee you somewhere along the line there's something going on. That's where you have to dig. But based on this scenario, this is an example of where you wouldn't meet that criteria, okay? We'll do one more, right? So 32-year-old female considered 3 weeks difficult sleeping, eating, concentrating, low energy. Feels guilty about these symptoms, can never focus on her children. She's still able to accomplish work and responsibilities without a problem. No SI, HI, and a benign exam today. So now we have that same scenario, but we've changed it. So now what is this person's diagnosis? Yeah, it's just sad, right? Then we're not having that effect at home. We're not having difficulty, responsibility with the problem, right? So how would you treat this? Yeah.
Sorry, I took the keeping her from ghosting her children as an effect of her life.
Okay. But when we're looking through, she's still able to accomplish work and home responsibilities without a problem, right? So yeah, she feels guilty about it because she's not able to focus, but that goes into the concentration ability, right? She's having a hard time focusing on her kids, getting those things accomplished, making sports games, soccer, and stuff like that. Cool. Again, this one is kind of, it starts to hit that vague area. I would probably make it a little bit more clear cut than this. But it's a good example of how that criteria can change over time. All right? Good. And I think that's good for today. The rest of these are in there. You guys can definitely kind of read through them and stuff like that. And I think tomorrow we'll try and do 3 lectures. So I think I have like a 4 block. And that'll leave you with 2 left, so we can knock them all out next week, and that'll leave us the next block to do a review. I'll make the review optional, so you guys can come if you want to, but we'll kind of run through a lot of these questions and see if we can clear some stuff out before the test. Okay? Anything else for today at all? Cool, that's all I got for y'all.